Good morning, everybody. I'm going to talk to you today about a topic that surgeons like to maybe not talk about all the time. But it's very important. Very important to have some introspection. I hope you understand the word, introspection. We'll see what that means in a while. Because surgical ego, it's like the movie. Some of it is good. We have to be egoistic sometimes. We have to have a strong ego. But sometimes it gets bad, and even worse, it gets ugly. First of all, what is ego? Two different ways of defining what an ego is. Freud, Sigmund Freud, had a psychoanalytic theory of what ego is. He thought it was that part of our personality that maintains a balance, an equilibrium, between what we feel, what we are impulsed to do, and what our consciousness says we should do, what we call the superego. It's a difficult way, a difficult balance between the two. If you go into the dictionary, you have a little bit different definition. First of all, you have the psychological aspect. It's the I. The I. Everybody knows the I for the ego. It's the person who thinks, it's the person who feels, it's the person who's willing to do something, and everything else that distinguishes himself, the person, from the others. Psychoanalysts, it's also very difficult to define, but they think it's the part of our ego that relates to past experiences. And there's a difficult balance, once again, between what we think, what we feel, what we want to do, based on our experience. Okay, definitions. Everybody happy with that? How many of you are surgeons here? All of you are surgeons. Nearly all. There's a problem with surgeons. Their ego is much stronger than anybody else. Why? Well, most surgeons think they're God. Or at least they think like God. Or at least they think they should be God. Why? Because they have a very privileged part of the life of their patients. Patients come to them, they're suffering, they have disease, they need somebody, they need a priest, but not a priest who's going to give absolution. They need a priest who's going to heal, that's going to comfort them. And this gives us a strong ego. It's a good feeling. This is what surgery is about. This is what medicine is about. So, a strong ego can be something we need and very beneficial. Very famous person today, but this was many years ago when he said, a healthy ego leads to a higher quality of work. Oh, say, that's good. And this guy said, yeah, my helmet should fit my ego. In other words, the ego is much bigger than the head. I don't know if any of you, I'm sure that some of you remember the name of Christian Barnard. Christian Barnard was the first heart transplantation surgeon in South Africa. He was cited 1967. I have a tremendous ego. I know that. And I must feed it, or I become miserable or unhappy. And I know that people enjoy my failures more than my successes. My early loneliness stemmed from insecurity. I have enjoyed world fame, beautiful women, and I have shunned none of it. Very famous person. He said a lot in those words. failures, loneliness, insecurity, and this is the way he battled against all of this. Strong ego, very important. Strong ego also is something very important when you do things like mountaineering. I think one said that I was a mountaineer. You need a strong ego to go and continue. This is the Hillary Rousseau in Everest at the end. You're at 8,800 meters. You can't breathe. You can't walk. But you still have to climb the Hillary Rousseau here. You have to get around it. It's the only difficult part, technically speaking, of the Everest. Only one. The rest is just walking. But you need a strong ego to do that. You need an ego also to make good decisions. I don't know if you remember Chesley Sullenberger in New York. He had to make a decision, a very strong decision. His plane took off and birds flew into the motor. He had to come down into the Hudson River. And he did it. He did it. He saved everybody's life. Strong courage, but a high and strong ego to do something like that. Surgical decision-making is, as Don Trunke has said, a combination of experience and judgment. Good judgment comes from experience, but experience comes from bad judgment. So, decision-making is a combination of experience, judgment, but being capable. Being capable means you need your ego. And that's where decision-making comes in. You need strong self-confidence. This is the most important part of our ego part of our surgery. Very important. Otherwise, who in the world would be other than to do an emergency room in the ED, emergency room thoracotomy? You have to be able to do it. You have to be able to think what you have to do, make the decisions in order to save the life of the patient. You have to also be able to take care of, where's my pointer? A vena cava injury. There's blood all over the place. You have to be calm. You have to have a strong command of what you're doing in order to get the hemostasis done. You have to be able to also to take care of a heart wound. If you have to do a thoracotomy and take care of a heart wound with blood coming all out of it, this patient is going to depend on you. You have to be able to do it. That requires a strong ego. Okay, everybody happy with a strong ego? Good. Sometimes it's bad. It leads to incorrect behavior. I'm going to go from the mild to the stronger. Every day when you read papers, publications, you see what we call publication pride. This is the largest series. We were the first to do this. We were the only center capable of doing that. You see that in publications. That's nothing more than ego. Displaced ego. Because who cares? Only you. The other people don't care it's the largest series. And it's not because it's the largest series that it's going to be the best. And every time you say it's the largest series, there's always somebody going to say it's wrong. I have the largest series. Another ego. We were the first. No, there's always somebody to say that they were not the first. Take this example. Everybody knows this example. And I'm very proud that I found one in Spanish to say that it's not the first. 1949, 2005. Einstein wrote a formula. Energy is equal to the mass and to the square of the speed of light. But he also wrote another formula, that ego is inversely proportional to your knowledge. The more knowledge, the lesser the ego. The lesser the knowledge, the more the ego. Let's go a little bit further. Surgeons don't like to talk about failures. William Hadstead was reported to say this: I have no failure to record. 1893, Johns Hopkins University in Baltimore. If we exclude the recurrences, not a failure for him, which were not in my method, not me, what else is this but just poor reporting? Ego. So we've looked at undaunting decision-making, pride. But ego was also something that is unlimited self-esteem, narcissism, chauvinism. Narcissism, we all know what narcissism is. Chauvinism came from the French Revolution, when Guy de Chauvin said, this is the way we got up to go, this is la France, vive la France. What does that lead to? That leads to patients, surgeons. This is a top surgeon who spoke of a very close and prominent colleague who's never mentioned in the mortality count. Never. He never had a complication. So there's only two explanations. Either he doesn't operate, can't operate, doesn't have any complications, that's for sure. Or there's a code of silence. And the code of silence is based on the ego of the person who imposes that. Please, this is a very bad part of ego. You have to get rid of it. Another very famous surgeon, Eduardo Bassini, who after he described his technique of hernia repair, he wrote, it would be risky to publish more about radical treatment of hernia. I've done the job. No one needs to do anything more. Surgical ego is a barrier to what I said in the beginning of my talk, to introspection. How many times do we hear stories like this? A patient and his family come to see a surgeon. He has cancer. What's the answer? What's the question? Doctor, after the operation, did you get it all? Did you take the tumor out? Doctor says, the procedure went perfectly well. No problem. Technically. What do you mean technically? Okay. When will you get the path report? I expect you'll be home before it gets. Everything is perfect. You're going to go home. Don't worry about it. That's how well you're doing. Well, you need chemotherapy. Well, we have a terrific group of medical oncologists here. I'm going to refer you to my favorite. She'll answer all of your questions. Believe me, that means he can't do it. He doesn't want to do it. But doctor, the cancer. Don't worry about the cancer. The operation was a piece of cake. That's what happens. Other things. Doctor, is it bad? Could not be worse. Tell us, this is the family. Without an operation, he's dead. Without an operation, he's dead, my God. He needs an operation as soon as possible. Very special, difficult operation. So who can do this? There's only one person that I know. It has to be done by an expert. I only know one. Where is he? Where is he? He's standing in front of you. Lack of introspection. Physician ego leads to failure to accept errors when you make a wrong diagnosis, especially in front of your colleagues, especially when the colleague is a young colleague. The problem is, why is it bad? Because it leads to repeated investigations, because you're sure that you need another, maybe if you did another CT, maybe if you did another MRI, you would find something wrong and you would be right. For the time being, you're not. Or even sometimes I've seen people prescribe a hernia operation, for instance, for people who don't have a hernia, because they want to have the possibility of saying that, yes, she has a hernia, I made the diagnosis, so we have to operate it. Or delay, because we need another investigation, or we need some confirmation, all leading to increased costs and communication. Errors are absolutely part of a bad ego. Ego with your paramedics, with your boss, with everybody around you. It leads to disaster. Disaster. You have to take care of patients. You want your image to be good to the patients as well as to the surgeons. Take this citation from 2012. When cognitive resources reach their limit during critical and uncertain moments of an operation, the consummation of resources by the pressures of reputation and ego might interfere with the thought process needed to take care of the patient, to execute the task at hand. Recognizing these external social pressures can help the surgeon to self-regulate, respond mindfully to these pressures, and, of course, prevent surgical error. All this is important. Why? Because in not all cases, but sometimes this is how a ureter gets cut, or a bile duct gets cut, or a laryngeal nerve gets cut. I know where it is. I know where the anatomy is. I don't have to worry about it. I don't have to take any precautions. Check, 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 check. See how well I am. Good. Afterwards, the day later, week later, a month later, we find the injury. Surgical errors are sometimes due to fatigue, personal worries, time pressures. Everybody knows. But bile duct injury is probably caused also by patients, by doctors who are in a hurry. And this is part of the ego system, the bad part of ego. You have to be very careful. Don't forget, when you take risks, you're not taking risks for you. You're taking the risks for the patient, for others. Dangerous behavior is something that we all, dangerous behavior happens all the time. But in surgery, can be a disaster, a disaster. There are dangerous behaviors. Insertion of a varus needle into a scar. Direct trocar. I've seen a very famous French surgeon who doesn't make an incision on the skin. He pulls the skin up and puts the trocar in. He no longer can exercise his profession because he's in jail. It's also an egoistic characteristic of doing a total colectomy with a pouch reconstruction and only doing it once a year. Or a pancreatoduodenectomy, only doing it once a year. This is not normal. But there are surgeons that want to show that they can do this operation, even if they do it once a year. What does that mean? That means these surgeons are very, very proud, very egoistic, and for me, all this shows is that the limits of resection are often defined by the plasma tests that show it. Okay, let's go a little bit further. ego can be very dangerous and very bad. This is a case of a surgeon in England. He's in jail because around the beginning of the century, he did an ossifragectomy, and the patient died. The autopsy said he did a resection, but he didn't do the anastomosis. Can you believe it? He got fired, but he went to another hospital. He did the same thing. Unbelievable. Even to a lesser degree, I think that many colorectal anastomotic leakages happen, but what does a surgeon say? I never saw a patient with so fragile child. Not his fault, it's the patient's fault. Postoperative bleeding. Never saw a patient that had such poor hemostasis. He must be a drinker. Or the patient died. I never saw a patient with so much comorbidity. So, strong ego prevents honest morbidity and mortality conferences. It prevents good consensus, healthy attitudes to the patient, or admitting that something's going wrong during an operation. And I think we have to have not only introspection, but also I'd like to cite Oliver Cromwell, who said, "I beseech you, in the bowels of Christ, think it possible that you might be wrong, that you might be mistaken." Ego can play a nasty role in academia. Wanting to be famous can go to such a degree that the person feels that he is right, he knows he's right, and he will do everything to prove that he is right, and get blurred. And this is some of the frauds that have occurred in the medical literature. These people are cited because they have fabricated or falsified data to get a job done, and even this guy won the Nobel Prize. He went to jail, and he had to give the money back. Okay, I'm not going to talk about this one. Andrew Wakefield, very well known in the United Kingdom, who wrote about the link between measles and mumps vaccine and autism. He was convinced that he was right. And why? Of course, he made a company. He had a company that was responsible for that vaccine, but everybody found out that the vaccine was not working, and patients were dying because of that. This is something very bad, is what they call confirmation bias, or my side bias. Physicians refer to information, they interpret that information in such a way so that their ego drives them to a decision and to a way of talking. And if you are a boss in a hospital with something like that, you're going to instruct your students, your fellow colleagues, in the wrong direction. This is a very bad consequence of ego. And you can go down a false path. Going down a false path means that, I've never had one, and this Strasbourg has insisted on the way. This is how bile duct injuries do occur. It's not because you've never had an injury that you can have an injury someday. And your ego has to be curbed in order to make sure that every time you do a simple cholecystectomy, you're not going to have a bile duct injury. And be fixated by what we call cognitive fixation. In other words, once an error has occurred during the operation, you don't want to admit it. And you keep on pertaining and perceiving the fact that you cannot be wrong. And you continue and you make things worse. One other thing. surgeon ego and live demonstration. There's no other platform that I know of where surgeons' egos get higher and bigger. Look what I'm doing. How many times have we seen disasters in live surgery? I'm sure everybody knows of them. The first time I saw a laparoscopic cholecystectomy, I'm not going to say the name of the surgeon, very famous German surgeon, operating in Portugal. And he says, this is how you do a cholecystectomy. It's so easy. This patient is a little fat. That's okay. Okay, make another trocar. Okay, another trocar. So we have 6 trocars for a cholecystectomy. Where is the gallbladder? Where is the gallbladder? What do you mean, where is the gallbladder? This is in front of 150 people looking at the screen. So I can't find the gallbladder. Must be over here. Cut, 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 cut. And then he goes away. Patient is bleeding. The people look at it. Obviously, he didn't cut anything else but the common bile duct. Very famous surgeon. None of you know him, I'm sure. That's okay. Problem is, when you're on screen, you're on television, you have to finish the operation. You're showing yourself. You can't convert. You're on stage. You're pressured. You're not going to listen to any criticism. You're showing off. You're not going to admit that anything could go wrong, that you're making a wrong decision. And you pursue, and you pursue, and you finish the operation. This is the problem of live surgery that I've written about with Alfred Kashiri and Bertrand Millat. A couple of years ago, I was invited to South Africa. I can say it's South Africa. And I saw a very famous surgeon doing live surgery. At that time, this was a distal pancreatectomy. So here we go. Little problem with the splenic vein. Okay, pretty good. Looks very nice. What happened there? Okay. This is not a hemostatic instrument, you know. Suction device doesn't do anything for the patient except take away the blood that's been lost before. Oh, getting worse, getting worse. The anesthesiologist said, what's wrong? I don't have any blood pressure. Said, no problem, no problem. Just wait a minute. No problem whatsoever. Now we're getting worse and worse and worse. This operation went on and on and on for 3/4 of an hour before the surgeon finally opened up and admitted that he needed help. Surgeon ego. Very bad. Very bad. Okay. Surgeon ego leads to taking shortcuts. No splenic flexure mobilization when you have an anastomosis that's going to be under tension. Not doing an intraoperative cholangiogram after an operation to make sure that you don't have a bile duct injury. Or testing for air tightness after. It takes more time. But what else is it than surgeon ego that's saying, I cannot have a splenic flexure. I cannot have an anastomotic leak. I've never seen one. I've never had one. And I don't have any bile duct injuries. And I don't have any problems when I do operations. My last part is going to be what we call disruptive behavior. And the disruptive behavior now is the limit between what is bad and what is ugly. What is disruptive behavior? It's anything that interferes with the orderly conduct of hospital business, from patient care to committee work. Doesn't matter if you're taking care of patients, it's also your relationships with everybody else. It includes behavior that interferes with the ability of others to do what they're supposed to do. Not only you do what you're not supposed to do, but you tell other people to do things that they are supposed to do, not to do. This is unbelievable. And it's a threat to patient safety. It's a threat because when you yell and you insult, very dangerous and very bad language. And what happens? Disruptive behavior can lead to wrong side surgery. It can lead to pranks in the operating room. New Orleans, a surgeon fired a stapling gun into the buttocks of a nurse when she was bending over. Unbelievable. But it's only because he knew he could get away with it. He didn't care about the $5,000. He was, and this is the worst. This is a surgeon doing an operation. There we go. Hernia. Cardiac arrest. What's going on? What's going on? The anesthesiologist comes. What's wrong? Boom. Get out of here. So we see that ego has its good sides. It has its bad sides, and it has its ugly sides. If I can conclude, we need ego, but we have to control it. Some say that behavior patterns come from stress. Everybody is stressed. Just don't take it personally. So, ladies and gentlemen, take a look around in the room where you are. How many of you recognized your partner? How many have recognized yourself? My message: step out of the mirage of your own egos. Observe your own behavior. Practice being truly, painfully, and honest, first with yourselves and then to your patients. Thank you for your attention. Special tips is that you have to realize it. You realize that your ego can get the best of you. And even if it's because of stress, you have to control it. Not so much the stress. You can't control the stress. You're stressed. But control the bad behavior because of the stress, especially bad behavior to other people in the room. This is very, very common to hear surgeons that talk very poorly to the nurses, to the anesthesiologists, just because they are stressed, because they have a problem. You have to be self-controlled. You have to have good self-control to make sure that you don't be one of these people. It's not easy, but it has to be done. And it's good that the residents learned about this early in their careers, not late.
Rodrigo, nice job. I love the equation, the Einstein equation about ego and knowledge.
Yeah.
It was great. So do you think that ego must be related also with insecurity? People that are maybe insecurity of themselves shows like a big ego.
Exactly. Their lack of self-confidence. Lack of self-confidence means that they have to show off that they are confident in themselves. And it can lead to disasters. We have to realize it in order to control it.
Do you think there is an age you can change, or there is this problem, say, well, this is too old, it's never going to change?
It's up to each individual. I think, why I give this talk, I think this talk makes you realize what can happen if you don't have that self-control. So it's up to everybody individually to correct it. The chief can't correct somebody who has a bad computer, or you can kick them out, of course. But if you get kicked out, sometimes they start over in another hospital. It's up to everybody to, it's like the teaching responsibility that I talked about yesterday. It's up everybody's responsibility to realize that it's important. And then once you realize that it's important, you do the job. You do what you're supposed to do. Yes, please. Yes.
Hi, thank you for the conference. It was very interesting. I was wondering, since having a strong ego, I think it's equally important as having a very well introspective or autocritic criticism, let's say, after surgery. Are you aware of any? You've been around a lot around the world, and are you aware of any? I don't know, conferences or maybe some courses or something like that to boost younger surgeons' egos sometimes when they are lacking one, or to downsize maybe big egos when you need to do that? Because it's very important, and you see that maybe chief of residents are doing that all the time, you know, putting down one that is very big and very reckless and boosting the one that needs to be boosted. So I think that would be something that maybe societies as a whole should be looking at.
I do that. I teach that. I've taught it in my hospital. I've taught it in France. It's not well received. Let me say something. And there's a recent paper in Annals of Surgery by, I don't remember, I know that Keith Limo was one of the authors, one of the co-authors, where they did a survey on instruction to residents and giving them at one time, to find out at one time they have the confidence that they need to do an operation, to do a big operation like duodenal pancreatoduodenectomy or a IBD disease or whatever, a big operation. And it's very uncommon that a resident after 2 years or 3 years, or it's not uncommon, let's say, after 2 or 3 years that a resident is not confident enough to do that operation. The conclusion is that we need to do more instruction to residents. What you're asking for is something that has to be done. I agree that it has to be part of the curriculum. When we teach in the hospitals, we have to concentrate on at least once or twice, maybe every semester, every 6 months, to talk to the residents, see where their confidence is lacking, and see how that can be changed, supported. It's not only a part of knowledge, but it's also being able to say something, I know you can do it, and I know you do it well. I think somebody wanted here first, and then you.
Yes, thank you very much for your conference. Excellent. I think one of the problems is that those who have a very large ego maybe will not acknowledge this situation themselves.
Exactly.
So I think this is the key point in which it's so difficult to educate this ego.
That's why I'm showing that.
Yeah, that's right. But if in the case I had a very large ego, I would say, okay, all this you showed is okay, but it's not happening to me, right?
Yeah, but that's the same thing that's about the bile duct injury.
Right.
I never had one, so, or I never had a recurrence.
And all the complications I had would never be because of this little fracture called ego. But I may find 100 factors except for that. So, as you said, it's very important that in the stage of early in your career, like residents, to be educated in this too. But
Exactly.
formal education on this, or is there? I don't know about it.
It's not a formal education. No, it's not part of any curriculum that I know of. I took this up because I thought this was a very important problem, and I saw people doing very dangerous things because of their ego. And I said, then we have to talk about it. We have to talk about it to our residents. We have to talk about it. I've done this in public also, in congresses. It's an awakening experience, I hope. Yes?
Yeah, thank you for your talk. It's a pleasure to have you here. I think we have to differentiate two things, basically, and that is what is ego and what is self-esteem. Because ego, I think, drives you to doing things that are wrong, and self-esteem drives you to do things that are right. What do you think about that?
Yeah, the problem is, where's the limit between self-esteem and ego? Very difficult to define. That was the first part of my talk. Where's the limit between the two? I don't know. Because self-esteem means what? It means thinking that you are capable. And if you think you're capable, that means sometimes I'm more capable than somebody else. Being more capable of somebody else means you think you're better. So you see, there's a stone that's rolling down the hill, gathering moss all the time. Where's the limit? We don't know. Yes?
Thank you very much for your talk. We talk about ego. Do you think there is a humble surgeon? And does it have any cons of being there?
I've seen very, very good surgeons. I'll tell you one person that I've never heard say anything of the sort. It's Tom Starzl. Anybody ever hear Tom Starzl talk? I've never seen him or heard him say anything that would, even the esteem that he has for himself, that went overboard. I've never seen that. I had a very famous mentor. It was André Toupé. I'm sure you all know the Toupé operation for anti-reflux. André Toupé was a colorectal surgeon, as a matter of fact. He was not but he was an inventor. He was an innovator. And he got into a fight with somebody, a verbal fight, somebody else very well known in France, Lorta Jacob, who was the first person to do a hepatectomy, open surgery. And this was because of a Heller operation that went bad, and Lorta Jacob said, you have to do my operation, which was attaching the greater tuberosity to the left, to the right, I'm sorry, and the left of the crus in order to make sure that the myotomy stayed open. And Toupé said, no, this is ridiculous. You have to do it from behind, not in front. And they got into a big fight. But then Toupé published that. And that was the motivation to do his operation. Then he saw, like Nissen, that it worked for reflux. And this was the beginning of the Toupé operation. Do you know that Toupé, in his career, I worked with him for 2 years, more than 2 years. In his whole career, he did 16 operations, 16. How many thousands, hundreds of thousands of Toupés have been done since laparoscopy has come about? But anyhow, Toupé was a very modest person. He never said, this is the best operation. He never said, I am the best. He said, yeah, this is how I do it. This is what I believe. Now you take it and you do whatever you want. And this is why me, as his pupil, I never did Toupés afterwards. I did something else. That's another story. Yes?
Thank you for your lecture. I think it was really good. We've already concluded from your lecture that maybe we need ego as surgeons to do the kind of work we do. But I think, and I want to know your opinion about it, if maybe it's not the ego that's the problem, but when you combine that ego with other bad personality traits, and maybe you have to work on that personality traits and not on the ego itself.
Good remark. Very good remark. That joins a little bit, perhaps, of what he was saying there. I have to think about that. Put it into my talk. Thank you very much.
Some question. Last one. I tried to invite some people of the administrative area that are friends of mine. I said, it's coming up people to talk about the ego of the surgeon. And they told me, this is just a surgical problem.
Typical, typical.
¿Alguna otra pregunta? Okay. Okay. Thank you so much.
Thank you. Thank you, doctor.